So just like my talk earlier this afternoon when I talked about surgical neck fractures, I'm going to talk to you on proximal humeral fractures. I'm going to talk to you now about radial neck fractures and how you can avoid unnecessary surgery for these patients. And we'll divide this talk into these areas: classification, diagnosis, the demographics, who are the people who are sustaining these fractures, a treatment algorithm, and my personal results with non-surgical treatment in the appropriately selected patient, as well as some published results. So Mason described this classification almost 60 years ago, and it's still a very useful classification for radial head fractures. Now, Mason described type 1 as a single fragment undisplaced and type 2 as a single fragment displaced. Often you can't determine the displacement unless you have appropriate radiographs, and we'll talk about that. His type 3 were multiple fragments, all displaced. And then another researcher added type 4. Mason never described a type 4, but further work suggested that if you had a radial head fracture associated with elbow dislocation or other elbow fracture, it may determine, the associated fracture may determine the treatment for the radial head fracture. So that's an important qualification. Most of the radial head fractures we're going to talk about are isolated injuries. But in type 4, there may be an elbow dislocation, there may be a Monteggia type injury, and those radial head fractures may require specific treatment. And the people speaking after me are going to talk specifically about those patients. So the history is usually pretty straightforward: a fall in the outstretched hand or a direct blow in the posterior elbow. And it's often associated with a feeling of instability. They say when they fell, they felt something in their elbow. They felt their elbow move or slip and slide, and it was very painful. So it may be associated with a transient episode of elbow instability, and that's a good sign that this may be a little more complicated fracture than you thought. Now, we're currently, where I work in Canada, we have two seasons for radial head fractures. We have the summer season, when people fall off their bicycles and land on their hand and break their radial head. And we have the winter season, when they slip on the ice, put their hand down and break their radial head. So we see a steady supply of patients with radial head fractures. Now, the physical examination is useful in that these patients will have a decreased range of motion. They will have a palpable effusion in the posterolateral corner of their elbow. That little dimple that's usually there will be absent. And they also have local tenderness directly over the posterolateral elbow, and that tenderness can be elicited by rotation of the forearm. So pronation and supination of the forearm with your fingers over the radial head will pinpoint for you where the problem is. Now, these patients occasionally will have crepitus, and that's a very important prognostic sign. So we try to elicit crepitus if it's present. Now, the X-ray, on the X-ray, you often cannot see the fracture line. On the initial films from the emergency department, someone takes an AP and lateral X-ray of the elbow. There's no fracture line, but there often is a so-called Sale sign, which is a sign that there is an effusion in the elbow on X-ray, and that is a sign for you to look further for the radial head fracture. And I find the most reliable views is to have an AP view of the elbow in full supination and an AP view in full pronation. And between those two views, plus the standard AP view, you'll almost always see the radial head fracture. Now, associated injury can be important, as I mentioned, and if it's not evident on routine views, there may be special views, as I mentioned, the pronation, supination views, CT scans, if you're concerned about associated injuries, particularly coronoid fractures, and MRI may be useful to show some ligament or capsular damage, but we do not use this routinely. Now the demographics, this is the commonest fracture in the adult elbow. It's more common than olecranon fractures, certainly more common than supracondylar fractures. In this paper by Cass in the Journal of Elbow Surgery, they found that the male to female ratio was significantly skewed in favor of females. And you can see the average age for the females was about 10 or 12 years older than the males, suggesting that the male fractures were occurring with more significant force than in the female group. In this paper in Clinical Orthopedics and Related Research, they looked at a large number of patients. I want you to note here that out of 330 patients, 81% had mostly uncomplicated radial head fractures. 2/3 of them had Mason type 1, which is the undisplaced fracture. Another 14% had Mason type 2, which is the single displaced fragment. And then 20% had the more complex Mason type 3. So approximately 20% of these patients, almost by definition, will require surgery. But the important thing is that the other 80% will not. Now, 39% of the patients had associated injuries, which is the important thing in determining whether or not these patients need surgery if their radial head fracture alone does not indicate surgery. So 16% with a coronoid fracture, 14% with elbow dislocation. And later in this symposium, we'll talk about the significance of radial head fracture in the face of elbow dislocation and whether or not this will determine the type of treatment for the radial head fracture. So the treatment algorithm in our clinic is type 1, no surgery, type 2, no surgery unless there's an associated injury or another problem, type 3, almost always surgery, and type 4, almost always surgery depending on the associated injury. So our treatment here is early motion for type 1. We don't aspirate anymore, and we don't use local anesthetic in these patients anymore. We just see the patient, confirm the diagnosis, and start them on an early range of motion program. And here are a couple of papers that I've quoted that are confirm that this is an appropriate approach to this type of patient. And here's a typical Mason 1 fracture. You can see the fracture line in the radial head, but there's no displacement. Now type 2, where there is displacement, it's worthwhile aspirating the hemarthrosis and injecting some local anesthetic. This will allow you to examine the patient's elbow accurately. Otherwise, they're too painful. So you assess their range of motion, and if they have full rotation of their elbow, if their elbow is stable, and if there's no crepitus, they can be treated with early active motion, the same way as we treat the type 1. So this is very important. And these type 2 fractures, which are relatively rare, okay, maybe 15% of the total, this is what you have to do to make sure that conservative treatment is appropriate. Now, early active motion will provide good results, okay? Atkinson has written a paper in JBJS British in 2006, reviewed a large number of patients and recommended non-surgical treatment for these patients. And the results were equal or better than reduction of fixation without the risk of the complications of surgery. And these are 2 trials that were written, one in the Journal of Trauma and one in JBJS American. And so these were trials where they compared non-operative to operative treatment for type 2 fractures, and they found that non-operative treatment was superior. And here's a typical type 2 fracture. You see that the little edge of the golf tee has been pushed down. That's why it's important to make sure they have a good range of motion so that there's no block at the proximal radial ulnar joint, and make sure there's no crepitus, because if there's crepitus, it shows that the fragment is probably loose. Then in type 3, there's a lot of controversy. I'm not going to dwell on this. This is going to be discussed later on this afternoon. So open reduction internal fixation alone or with replacement, and then ORIF, what type of replacement. A lot of questions about radial head fractures that require surgery. I'm trying to convince you that the majority do not require surgery. And here's a typical type 3. You can see this is a Monteggi equivalent. We're going to have a talk about this later on today. And type 4, the treatment depends on radial head fracture type, associated fractures, and associated instability. So the protocol for type 1 and type 2, local anesthetic for assessment in type 2 patients only, vigorous self-directed physiotherapy, intermittent splitting for pain relief. Failure to progress by week 3, we start them on a formal outpatient physio program, but most of these patients do not need a formal physiotherapy program. So this is my personal group of patients over the last 2 years. You see they're quite a bit younger than the published. That's because they're either ice skating or riding their bike, so they tend to be quite a bit younger. And it's at 1 year following injury, you can see that the rotation is minimally diminished compared to the opposite side, as is flexion and extension. So these people basically think they have a normal elbow. Their DASH score is 7. The range is from 0 to 60. The 60 DASH score is a patient who was on workers' compensation. And here's a paper just published 2 weeks ago. I thought you'd enjoy this. This is the long-term outcome of isolated stable radial head fractures from the people in Edinburgh. And their final comment is, we suggest that routine primary non-operative management of these fractures provides a satisfactory outcome for the majority of patients, with few patients in our study requiring further intervention for persisting complaints. And that's certainly my experience. The great majority of stable radial head fractures do not require surgical treatment. This is a common injury, rarely needs surgery. A stable non-crepitant elbow allows early active motion, and non-surgical treatment of Mason 1 and Mason 2 yield excellent results. Thank you.